It is 11:47 p.m. on a Tuesday. A man walks through the automatic doors of a Level 1 trauma center in Columbus, Ohio. He is holding his left arm. Behind him, a woman is being wheeled in on a gurney, unconscious. 2 minutes later, a teenager arrives. Fever of 104. They all need help, but they will not be seen in the order they arrived. This is not a failure of the system. This is the system working exactly as designed. Every year, approximately 145 million people visit emergency departments across the United States. That is roughly 16,600 patients every single hour. No emergency department has the capacity to treat all of them simultaneously. So the question becomes, how does a hospital decide who goes first? Now, the answer is triage. The word triage comes from the French verb trier, to sort. The concept was formalized on the battlefields of Napoleonic Europe. Military surgeons realized they could not treat everyone at once. They needed a system to decide who had the best chance of survival if treated immediately, who could wait, and who was beyond saving. That battlefield logic now lives inside every emergency department in America. Modern hospital triage is not a single action. It is a structured decision-making workflow, one that begins the moment a patient crosses the threshold of the ER. It is designed to operate under pressure, at scale, with incomplete information, and it has to work every single time. In the United States, the dominant framework for emergency triage is called the Emergency Severity Index. The ESI, developed in the late 1990s, the ESI is now used in the majority of U.S. hospital emergency departments. It is a 5-level classification system. Each level represents a different urgency threshold. Each level determines how quickly a patient will be seen by a physician. Level 1 is immediate. A patient whose heart has stopped. A patient who is not breathing. There is no waiting. Level 2 is emergent. The patient is in serious condition and could deteriorate rapidly. This patient needs to be seen within minutes, not hours. Level 3 is urgent. The patient is stable but requires multiple resources. Imaging, lab work, IV fluids. They will wait, but they will be monitored. Level 4 and Level 5 represent less acute presentations. A minor laceration, a sprained ankle. These patients are stable, and their wait time may extend into hours. The entire ESI classification for a single patient typically takes between 30 and 90 seconds. 30 to 90 seconds. To sort, to classify, to route. That is the operational window the triage nurse is working within. The triage nurse is the first clinical decision maker in this chain. In most American emergency departments, the triage nurse holds a registered nurse credential with specific emergency training. They are not diagnosing. They are classifying. The distinction matters. Within those 30 to 90 seconds, a triage nurse is gathering specific data points: the patient's chief complaint, vital signs, level of consciousness, and the anticipated resources the case will require. That last element, resource prediction, is what separates the ESI from simpler triage models. A patient with chest pain and normal vitals requires different resources than a patient with chest pain and a blood pressure of 70/40. The ESI asks the nurse to think ahead, not just about the current presentation, but about what the next 2 hours of care are likely to look like. This forward-looking design is intentional. It allows the department to allocate rooms, equipment, and physician time before the bottleneck forms. Behind the triage desk, the emergency department is running a parallel operation. The charge nurse, a senior ER nurse responsible for department flow, is watching bed availability in real time. When a high-acuity patient arrives, the charge nurse coordinates with the attending physician to activate the appropriate response, before the patient even reaches an exam room. In a Level 1 trauma center, a Level 1 ESI patient may trigger a full trauma team activation. That means a trauma surgeon, emergency physician, anesthesiologist, and multiple nurses are moving to a designated trauma bay simultaneously before the patient has been fully evaluated. Yet the system is not reactive. It is anticipatory. Every person in that sequence has a defined role, a defined position in the room, a defined set of tasks. The left side of the trauma bay belongs to one nurse. The airway belongs to the anesthesiologist. The primary assessment belongs to the trauma surgeon. Nothing is improvised. But triage does not only manage who comes first, it also manages the department's capacity and at the number of patients that can be safely treated at any given moment. This is called throughput management, and it runs continuously in the background of every operational shift. When an emergency department reaches a state where incoming patient volume exceeds available beds and staff capacity, the department enters what is called a surge condition. Surge does not mean the system has failed. It means the system has entered a higher operational mode. In a surge condition, the charge nurse may initiate a protocol that converts hallway spaces into temporary treatment areas. Non-urgent patients may be redirected to fast-track zones, areas of the ER staffed specifically to handle lower acuity cases without drawing resources from the main department. At the same time, hospital administrators receive notification. Bed management teams begin reviewing inpatient capacity. The goal is to move stable patients out of the emergency department and into the hospital, clearing space for the next wave of incoming patients. The triage system does not operate in isolation, and it is connected upstream to the pre-hospital system, the network of paramedics, emergency medical technicians, and dispatch centers that manage patients before they reach the hospital. When a 911 call comes in reporting a cardiac arrest, the dispatch center is already routing an ambulance and alerting the receiving hospital simultaneously. The paramedics in the field begin transmitting patient data directly to the emergency department before the ambulance arrives. Heart rhythm, blood pressure, oxygen saturation. By the time the patient comes through the doors, the ER team has already received a clinical report. The triage process for that patient has already begun in the field. This pre-notification system has been shown to significantly reduce the time between hospital arrival and definitive treatment, particularly for time-sensitive conditions like stroke and heart attack, where every minute of delay translates directly into patient outcome. Not all triage decisions are straightforward. The ESI is a tool, not a formula. It requires clinical judgment. And clinical judgment can be influenced by variables that are difficult to standardize. A patient who presents as calm and cooperative may be masking a serious underlying condition. A patient presenting with dramatic symptoms may be lower acuity than their presentation suggests. The triage nurse must read beyond the surface. This is why emergency nursing programs in the United States include specific training in triage decision-making, including simulation exercises that reproduce exactly these kinds of ambiguous presentations. Wow. The American College of Emergency Physicians and the Emergency Nurses Association publish ongoing research on triage accuracy and inter-rater reliability. The degree to which two different triage nurses would assign the same ESI level to the same patient. The data shows that ESI has strong reliability across Level 1 and Level 2 cases. Variability increases in the middle tiers, precisely where clinical judgment becomes most critical. This is a known limitation. It is actively studied, and it drives continuous refinement of training protocols across the country. But the physical design of the emergency department itself is built around triage logic. Modern ER architecture places the triage desk at the department's entry point, the first node in the patient flow network. From there, patient pathways branch based on acuity. High acuity patients move toward the critical care zone. Rooms with advanced monitoring, direct access to imaging suites, and proximity to the operating rooms above. Mid-acuity patients enter the main department, a grid of exam rooms managed by attending physicians and resident teams working in rotation. Low acuity patients are directed to the fast-track area, a separate zone designed to resolve simple cases quickly without disrupting the higher acuity workflow. This physical separation is deliberate. It prevents lower acuity volume from consuming the attention and resources needed for critical cases. It is not about prioritizing one patient over another. It is about matching the right level of care to the right patient at the right time. The triage system extends beyond the emergency department walls. In regions with multiple hospitals, regional coordination systems allow emergency medical services to route patients to the most appropriate facility, not necessarily the closest one. A patient in cardiac arrest may bypass 2 community hospitals and be transported directly to a cardiac catheterization center 10 miles further away, because that facility has the specific capability required to treat that condition within the critical time window. This routing decision happens in real time, coordinated between the paramedic team, the dispatch center, and the receiving hospital. And the result is a regional patient flow network, a system that treats the geography of healthcare delivery as a logistics problem and solves it with the same operational discipline applied inside the hospital itself. What does this system look like at scale? The United States has approximately 6,000 hospital emergency departments. Combined, yet they process roughly 145 million visits per year. That is a patient arriving at a U.S. emergency department every 2.1 seconds. Around the clock. Every day of the year. Behind each of those visits is a triage decision, a classification, a routing, a resource allocation. And behind each of those decisions is a nurse, a protocol, a department infrastructure, and a regional coordination network, all operating simultaneously, all dependent on each other, and all designed to hold under pressure. The system is not perfect. No system operating at this scale can be. But it is structured, documented, and continuously refined, driven by data, governed by evidence, measured against outcomes that are tracked, published, and compared across institutions every year. This is how a country manages emergency care at national scale, not through individual heroism, through system design. The triage nurse at the desk in Columbus, Ohio, will process dozens of patients tonight. Each one arrives with a different complaint, a different history, a different level of urgency. Each one will be classified, routed, and connected to the appropriate level of care, in a sequence that runs without interruption, from the moment the department opens to the moment the night shift hands off to the morning team. The man with the arm injury is ESI Level 3. He will wait. The unconscious woman is ESI Level 1. The team is already moving. The teenager with the fever is ESI Level 3. A room will open. Bap! The system continues. The lights stay on. The next patient is already through the door. There is a subscribe button below this video. It is a small action, but it helps document the systems that quietly keep millions of people alive. If you are curious about how American healthcare operates behind the scenes, the dispatch networks, the blood banks, the organ logistics, the supply chains, consider subscribing. And tell us in the comments, have you ever been through an emergency department? What did you notice about how the system worked around you?